Tom is talking today, and it's, as I said, a pleasure to welcome him here. We have collaborated, Montefiore, Einstein, and the Department of Health on a number of community health issues, and the vision of Montefiore to address the public health, the health of this population, this defined population, this geography, is something we will continue to work on. So, Tom, we have tremendous respect for the department, for your work, and we welcome you here today. Thank you.
How am I doing on the sound there? Does this work? Okay, great. It's really a pleasure to be up here at Montefiore. I've had a number of interactions with Montefiore since I took this position about 1.5 years ago. And it's clear that this institution is one that is particularly concerned with the population. And that's, I have to say, not the case for medical centers all over the country. That a medical center would take an interest in an entire population. But it is very much an interest of us in public health, because that is our job, to think about the entire population. So, I've enjoyed our interaction so far and look forward to working with Montefiore as healthcare reform rolls out and as the opportunities it offers appear. So my understanding is that the title for the symposium is New Clinical Health Research Paradigms in the Era of Healthcare Reform. And I want to talk about a health research paradigm, which isn't really new, but which I'm hopeful will be far more focused on, if that's a word, in the era of healthcare reform. And it's a public health paradigm. It's a way of thinking through health problems which people who are trained in medicine, like myself, tend not to use, but I think has great potential for health promotion. And as I'm going to explain in a minute, I'm hopeful will become more prominent in the era of healthcare reform. So before I explain that, though, I want to just start, as I start almost all of my talks, with addressing the question of what are our biggest health problems today. And let me make sure I've got this going here. And the simplest way to answer that question is to just look at mortality statistics. And these are our leading causes of death here in New York City. And I'm sure it's no surprise to people here the sorts of diseases that are the leading killers. We have heart disease. We've got, it's two-fisted. We've got cancers here. And we've got injuries of various forms. Accidents here, homicide and suicide there. With only a couple of exceptions of HIV and pneumonia influenza, this entire list is dominated by chronic diseases and injuries. And that may seem so obvious as to not be worth pointing out, but if I were to give you this list from 150 years ago, it would be entirely different. It would be dominated by infectious diseases. That was the list that really generated my agency, generated the entire field of public health, was responding to infectious diseases. But we're in a different era now, and we have to think, well, what's our public health response to this era of chronic diseases and injuries? And many people think that things will be transformed under healthcare reform, but just to point out what I think is the case is that, first of all, we don't know if healthcare reform is going to succeed. Okay, with the Republican takeover of Congress, they may roll it back. And on top of that, I'm told that these legal challenges to it are real, and it's entirely possible that the Supreme Court will decide that the entire bill is unconstitutional, and so it may not succeed. But even if it succeeds, we're still going to be having these issues which we'll be grappling with. We're going to be having increasing healthcare costs. Under the most optimistic scenario, healthcare costs will not go down, either in absolute terms or as a percentage of GDP. And those costs will be borne by individuals, by employers, by government. There's going to be, because of that, a calls for smarter use of health dollars. Chronic diseases, excuse me, chronic diseases will continue to be leading causes and I would say major preventable causes of death. And we're going to continue to have epidemics of obesity and diabetes. None of that is going to be changed by healthcare reform, and so we're going to have to respond to that. So one of the ways of looking at our health problems is just counting the diseases that kill us, as I showed you earlier. There's another way of looking at those health problems, and that's to say, what are the excuse me, what are the behaviors and exposures that lead to those diseases that kill us? And there's been a couple of attempts to try to classify our health problems by these behaviors and exposures. And here's a very simplistic one. It was originally done about 15 years ago and has been updated. And by this accounting, nationally, the number one, what they called actual cause of death, was smoking, responsible for about 18% of deaths. Then a combination of unhealthy diet and physical inactivity, responsible for slightly less, than alcohol consumption. Then you go on down the list. And the simplest way of summarizing this is to say that it's unhealthy behaviors that's killing us as much as it is chronic diseases and injuries, and that there's just a handful of unhealthy behaviors, which we all recognize, that are responsible for a large proportion of those deaths. There's a more sophisticated approach to looking at the causes behind the causes, which was done at a national level and which we updated for New York City. This looked at identifiable known risk factors and how many deaths that we can attribute to them, and also what diseases were the mechanisms by which those exposures killed people. And by this still we had smoking as our number one health problem. Then we had these other items here that still fall in the general category of unhealthy diet and physical inactivity. And then we have alcohol, again, and we have some other items here that have to do, again, still with diet and physical activity. So we can easily identify just a handful of health problems that are responsible for a very large proportion of our deaths, or to, I guess, put more accurately, that we could save a lot of deaths by simply changing those few number of behaviors. That way of summarizing our health problems is good, but it does not address those health problems which are chronic but don't necessarily kill people, such as mental health problems, such as arthritis, such as asthma. And so at the health department, we've taken our statistics and try to sort of summarize what we consider our primary priority health problems, and included those diseases which are cause morbidity but not necessarily mortality. And we come up with a list that looks kind of like this. And then we summarized that as priority, as well as some strategic approaches to addressing those in our strategic plan that we call Take Care New York. If you haven't seen this, just contact our office, and it's a nice book that in a fairly short way summarizes what we consider to be the biggest health problems and what are some ideas about approaches to addressing those. This is the summary of 10 items for things that one can do to improve health, and it's an invitation to organizations and entities across the city who want to do something on health to tell them how they can participate. Even that, though, still pretty much lays out the problem. It doesn't say how we should be approaching the solutions. And so to talk about a paradigm for approaching the solutions, I want to go back and think about how we dealt with our health problems when public health was first really established in the 1800s. Here's a mortality graph going back from that time period to today. And you see two very distinctly different time periods. Back here in the 1800s, we have very high overall mortality rates, and we have these big spikes. The big spikes are epidemics of things like cholera, smallpox, yellow fever. This is the era of epidemic infectious diseases. People were panicky in those days because of these epidemics, and they demanded the government do something. And that's what really created public health, was the government doing something to protect the public from these epidemics. We're in a very different time now where our mortality rates are far lower. We don't have these big spikes, and so people don't tend to demand that the government do something about it. Nonetheless, our mortality rates are higher than other countries around the world. They can certainly be lower still. And so we have to think, well, what are there lessons from this era that we can apply to this era? And there are. The era of epidemic infectious diseases was a time shortly after the Industrial Revolution where, really for the first time, huge numbers of people were crowding in cities. And no one really knew how to build a safe city at that time, and so there was little to no sanitation. This was an ideal opportunity for the spread of infectious diseases, which had not existed in the past as people lived in rural areas separated from each other. And this setting was perfect for a variety of epidemic infectious diseases. Among them was cholera. And this was in about 1840, the expertise of the day, what the scientists were saying we ought to do to respond to the cholera epidemic. And I want to just go through it a little bit because it's instructive. So their advice was be temperate in eating and drinking. Okay, that sounds sort of like what we're saying today. But avoid raw vegetables and unripe fruit. Okay, that's just the opposite of what we're saying today. Then they say, okay, above all, abstain from ardent spirits. But they say, and if habit have rendered them indispensable, take much less than usual. All right. So, but then other things here, they seem pretty simple. Sleep in clothes warm, don't sleep in a draught of air, avoid getting wet. When you look back on this, it really looks stupid. Let's face it. This is basically telling people on an individual level, you are personally responsible for avoiding getting cholera. And if you only took care of yourself, if it wasn't your own fault, you wouldn't have this problem of cholera. It's put all the responsibility on the individual. And we know that that was not true, that the solution to the cholera epidemic was not within the control of individuals. It was within the control of government or society at large. And that idea came first from one of my heroes in public health, a guy named Edwin Chadwick. He was operating over in England at that time. And he was hired to address the problem of unhealthy, of poor levels of health among the poor. And he, rather than assigning all the responsibility for their health on them individually, he said, you know, the problem is that they live in unsanitary conditions. And if we only provided sanitary conditions, they'll be far healthier, and they'll also be better productive workers. And he laid this out in the idea on this report called Report on the Sanitary Conditions of the Laboring Population of Great Britain. And it really, for the first time, it said the government needed to take responsibility for improving the conditions in which people lived. A radical idea at the time, but it's an idea that ultimately crossed the Atlantic, and it led to the greatest improvement in health in human history. If you remember that graph I showed you a while ago, if you look between about 1860 and about 1900, we had almost a 50% decline in mortality rates. Huge change. This was the Sanitary Revolution. This is when we built water and sewage lines, and we developed systems for safe food, safe waste disposal, mosquito control. This was really the heyday of public health. Public health was also, at that time, very much aligned with social reform movements that happened. There was child labor laws, and there was suffrage, and there was unionization. And public health was very closely integrated with that and not ashamed to be involved in these social movements. All those together were the solution to the era of epidemic infectious diseases, which have, for the most part, been vanquished. It's really been a great success story. And there are many people who are still thinking that the focus of public health should be on infectious diseases. To me, the focus is how can we take this principle and apply it to our health problems today? And so this is an example of our health problem today. This is the epidemic of our time, okay? Epidemic of obesity. This is body mass index from the 1970s and to 2000. As you can see here, everybody knows we have lots of people who are becoming obese. But what this says is it's not just that there is a small percentage of the population that has gotten a lot heavier. The entire population curve has shifted. This is an entire population level epidemic. Everybody is heavier now than they were 30 years ago or that their parents were 30 years ago. Even though our genes are the same, even though we are just as motivated, if not more motivated, to not gain weight. It suggests that this is an epidemic that is outside of individual control, like cholera. Nonetheless, our attempts to solve this problem are like this. This is something I found on the web, and I don't mean to be too tough on SUNY Buffalo. But if you look at it, this looks just as ridiculous as the cholera poster from 170 years ago. Develop solutions to your eating habits that are problematic. For example, if you know that you're eating fatty or fried foods, you can avoid those foods. Ah, very clever. Okay. Weigh yourself once a week at the same time. Develop hobbies and become socially active so you do not eat solely because you're bored. This says that everybody individually can control their own weight, just in the same way that everybody individually can control their own risk for cholera. And I think the data says it's not true, that we have a population-level problem, we need a population-level solution. So then the question is, what are the elements of our environment today, which are the equivalent of the unsanitary conditions from 170 years ago, that we can change to solve this epidemic? Well, there are many ways of thinking through that, but we've come up with a system of categorizing our environmental factors, which have an impact on our behavior and therefore on our health. And it's not a perfect system, but it does help you think through what you might be able to change to respond to population-level health problems. And the 4 items are accessibility of consumer products that have an impact on health. So much of our behaviors that I showed you earlier has to do with consuming some sort of product, whether it's tobacco, alcohol, food. And the basic principle is the more accessible it is, the more people consume it. Physical structures. We all operate in a physical world. We live in buildings and drive in cars, go on streets that have an impact on our behavior and on our health, and we can change that. Social structures. We all operate within some rules that a government or an organization has laid down that tells us how we should behave. We don't always follow those rules, but we often do. And if we change those rules, we can change the way that people behave. And then media. Increasingly, we live in a mediated world. We sit in cubicles and send emails to somebody 5 feet away and look at the screen. Everybody's looking at iPhones and iPads. It's all mediated, and we get images there that have an impact on the way that we think and feel about the world and the way that we behave. Advertisers have used that for a long time to change human behavior, and we can change that just as well. So let me give you just some examples of how these have been used or how they have an impact on our behavior now and how we might be able to use those for promoting public health. First, let's talk about accessibility. We know that if something is not present at all, we can't use it. And if it's present in abundance, it's easy to use. But what's surprising is if you can find many examples where even small changes in accessibility of products can have a big impact on people's consumption. This is one example that I love to show. This was an example a study done by market researchers way back in the 1970s that addressed the question, what happens to the sales of fruits and vegetables in grocery stores if you double the length of shelf space in which they're displayed? So you go, say, from 4 feet to 8 feet in the produce counter. Well, you know, they're always there. People who want to buy them can still buy them in either situation. But in fact, you get, on average, about a 40% increase in sales by doubling the length of shelf space, which is a little scary when you think about it. It implies that we are all pretty passive shoppers. The likelihood of buying something really is proportional to the likelihood that you'll bump into it as you do your random walk through a grocery store. And whenever I show this, I say, you know, if there are any health educators in the room, let me challenge you to say, if there a health education intervention that you know of that can increase consumption of fruits and vegetables by 40% reliably across an entire population? I haven't found one yet, but grocers can do it by just changing their length of shelf space. Well, with that in mind, what do our grocery stores look like today? Well, this is what most of them look like. And then you wonder, well, why do we consume so many of these products? You know, this is, by the way, not just an awful lot of Coke so that they don't run out of Coca-Cola. The amount of shelf space is there through a business arrangement between the manufacturer and the grocer, because they also know that shelf space is proportional to sales. So that's accessibility. Now, I should also say accessibility also has to do with price. By raising the price of something, it becomes less financially accessible to people. And so by altering price, we can have an impact on consumption. I'm going to come back to that idea. Let's talk about physical structures. This is a physical structure that could be anywhere in America. It's a street and a street environment that is not very conducive to walking. But one can imagine how you could change that environment by putting in a median strip, having buildings that are closer to the street, by even putting in mass transit, a bike lane. Suddenly this is a street that is much more, if you went through that, you'd be much more likely to walk or ride a bike, and probably more physically active and therefore probably healthier. So we could think about how we can design or redesign our neighborhoods in ways that make it easier for people to be physically active as a means of promoting physical activity across the entire population. That's physical structures. What about, here's another physical structure. That last one was a big one. This is a small one. You may think you're looking at a Motrin bottle here, but what you're looking at, in fact, is a child-proof cap. This was an innovation that was introduced around 1970 by federal law and to reduce childhood poisonings. It's a little small thing that most of us find just merely annoying, but in fact, evaluations say that it's reduced childhood poisonings by about 50%. This was put in place after a number of years of failure of the Mr. Yuck program. If anybody's my age, you may know about Mr. Yuck. And that was a time where we put stickers on bottles of things that were supposed to be poison with kind of a frowny face with their tongue sticking out. And you're supposed to teach your children, if you see that sticker, don't swallow that stuff. And of course it didn't work, but the child-proof cap does. So this small physical structure can make a difference. And think about that in terms of, well, now we also have Coca-Cola in 20-ounce screw-top, non-returnable bottles that physical structure makes it a lot easier to be sipping that all day long. What impact does that have on our consumption? Probably an important impact. All right, what about social structures? You know, we're all independent Americans, and we think of ourselves as not really paying a lot of attention to rules or government. But in fact, people do pay a lot of attention to rules. This is a great example from New York State. New York State was the first state to pass the mandatory seatbelt law back in 1984. This was after decades of government promoting people using their seatbelts, and seatbelt use was still across the country in the teens, like 17%. And then with one stroke of the pen, New York State said, you must, and seatbelt use jumped up to nearly 50% overnight. That happened in spite of the fact that New York State was not enforcing the law at all, and everyone knew that they were not enforcing the law. Just by virtue of the fact that some words were put on a piece of paper and voted on by a state legislature, people said, well, geez, maybe I ought to change my behavior in response. It wasn't 100%, but it did make a big difference. So it says that the rules that we live by have an impact on our behavior directly or indirectly, even if there's not enforced. Now, enforcement has now brought seatbelt use up to about 80%, but the rule itself really has a big impact. So that's a social structure. What about media messages? You know, in our mediated world, we are surrounded by images like this even today. What's the message here? The message is, if you smoke, that you'll be attractive and thin like this woman and very popular. Of course, that makes no sense whatsoever, but nonetheless, that is a message, and we do incorporate that message over time. And young, vulnerable people who want to be thin and popular, they take up smoking. This, of course, is not the truth. We can fight that by showing what is the truth, which is that this is what smoking does to you. That it makes you sick, it gives you heart disease, it gives you cancer, and it doesn't make you independent, it makes you dependent. It makes you, it's a drug. And because what we're telling is the truth, even though the tobacco industries may spend 10 times as much or 100 times as much as we do on advertising, we can win in that media argument. But we need to be playing in that field because that's where people get their information and their images about products. So that's a tour of thinking about what in our environment has an impact on our behavior and on our health. Just one example of how they all come together, I'll go right to the Coca-Cola company, which has an interest in changing behavior in the same way that we do. Their interest is in getting people to consume more Coke. So how do they do it? Well, as far as accessibility, they make sales available at every conceivable retail outlet, the vending machines everywhere. There was a CocaCola annual report that said that their goal was to have a Coke be within arm's reach of every American, and they're not far away from that. Physical structures, again, the single-serving, easy open, non-returnable containers. Social structures, they're very focused on policies that are preventing changes in policies that would limit the availability in certain settings. So there have been big fights over recent years about limiting sales of sugar-sweetened beverages or sodas in schools. And it's not so much the sales, I think, that they're interested in as the social sanction, that if it's okay in schools, then it should be okay everywhere. If it's not okay in schools, it makes us wonder, well, maybe it's not okay to have it in workplaces or other settings. And of course, there's advertising. Coca-Cola advertises in the billions of dollars. And none of that advertising is educational. It's all about changing our image of the product and what that product might do to us. So if the Coca-Cola company, which I view as really expert marketers that really understand environmental impacts on behavior, if they can use these ideas, well, we can use them too. So I want to talk about how we've tried to apply those concepts to smoking prevention in New York City, move on to some other ideas, and then I'm going to get back to the idea of where does research fit into all of that. So let's talk about smoking prevention. Number one, underlying cause of death in New York City as it is in the US as a whole. Our basic approach is smoke-free air laws, which has to do with accessibility and social structures, taxes, and taxes really is accessibility, counter-advertising, and access to cessation treatment. Smoke-free air laws really the biggest change was in 2002 when the law was passed by Mayor Bloomberg that banned smoking in virtually all workplaces, including restaurants and bars. That really changed. It did not only protected non-smokers from secondhand smoke, but it changed the image of smoking. Smoking became something that was socially unacceptable, or at least much more socially unacceptable than it was before. We're now proposing, by the way, a ban on smoking in parks and beaches that we hope will further protect people from secondhand smoke and also protect children from seeing this positive image of adult smoking. Accessibility has been addressed in New York City through taxes. Back in 2000, a tax on a pack of cigarettes was about $1.50. Through increases at the city level and the state level, we're now up at about $6.80. So a pack of cigarettes costs about $11. That's about the highest price in America. We have done a variety of media campaigns and continue to do media campaigns. This slide is a little hard to read, but what we're showing here is in the purple bars, when we're on television with our ad campaigns. And then the line here is the number of people who call to 311 requesting assistance for cessation. And so you can see that every time we run a flight, we get a spike. And we have a particularly good campaign, we get a bigger spike than others. Our most recent campaign, I think, has our biggest spike yet. That was our Reverse the Damage campaign that I showed just a minute earlier. And so, we can't subject our TV ads to randomized controlled trials. But we can at least look at this data, which is less than perfect, but it certainly is suggestive that we're having an impact on cessation. What's the overall effect? Well, before all this took place in New York City, for about a decade, smoking rates in New York City were about 21%. With the tax increases, smoke-free workplaces, and our counter-advertising, we're down now at around 16%, a little less. That's 350,000 fewer smokers. And we've done estimates for what impact that has on health. There's a way to estimate smoking attributable deaths. And our estimate is now that we're about 1,000 fewer deaths per year than we were in 2002. So you can say we're saving 1,000 lives a year. That's a big, broad population level impact. This is the form in which we're saving them. Those heart diseases mainly, then cancer and other respiratory diseases. Remember, though, that most of the health benefits of people quitting smoking now are going to play out over the next 30 years. And so we've actually done some estimates for how many lives the smoking reductions which have occurred since 2002 will save over the lifespan of people currently alive, and it's about 50,000. It's huge. So I think the point here is that before 2002, our smoking efforts in New York City were mainly based around school-based education. We were going to teach kids that smoking is bad, and then they were not going to take it up as a result of that. This change here reflects a different way of thinking about the problem. It's saying that smoking is not an individual choice. It has to do with being in an unhealthy environment. And if we change that environment, we can change smoking levels across the entire population. That idea ultimately leads to this enormous public health payoff. And so that's the paradigm that I'm promoting here that we should be using for other health problems as well. So let's talk about our other health problem that I mentioned here earlier, and that's our epidemic of obesity. This is trends in the percent of people who are obese by self-report through our annual telephone survey. Now, we know when people are asked to report their height and weight on a telephone survey that they underestimate their weight. So that this underestimates our total obesity rates. We're probably close to 30% of adults in New York City are obese. Another 30% or so are overweight. So we're about 60% people who are unhealthily overweight. When you get to 60%, you could say, in fact, it's normal to be unhealthily overweight. And when it's normal to be unhealthily overweight, that means the problem is not within individuals. The problem is in the environment to which all those individuals live. There are many things we're doing to try to address the obesity problem, and I don't want to talk. Let me just mention calorie labeling. So we required calorie labeling on fast food restaurants. That's important. But I do want to talk a little bit about our focus right now on sugar-sweetened beverages, because we think that these are not the entire epidemic, but they are a major force within the epidemic. And here's some of the thinking behind that. That we know that on dietary surveys, Americans are consuming about 200 to 300 more calories per day than they were 30 years ago, and probably about a third to a half of that increase could be accounted for by this one product. If you just look at the calories in the product, you can calculate that there's enough there so that if somebody added a 12-ounce soda per day for an entire year, they would gain about 15 pounds. Now, in real life, they don't gain that much weight, but it is true that observational studies do show an association between sugar-sweetened beverage consumption and either obesity at a cross-sectional level or weight gain in a longitudinal way. And for example, there's a study that shows that in each additional 12-ounce sugar-sweetened beverage would increase the risk that a child will become obese by 60%. And there even have been randomized controlled trials that show that if people reduce their consumption of sugar-sweetened beverages, they either have a reduction in weight or a reduction in weight gain. So putting that all together makes us think this is an important target in the overall epidemic. And so and this is just an example of our consumption per capita as measured by calories over the last 30 years. And this is this increase I was talking about from 70 calories a day to 190 calories a day. This is a huge increase over a relatively short time. And so we're trying to borrow some of the ideas that we've used from our smoking efforts. And counter-advertising is one of them. This is something that you may have seen on the subway, which just gives the visual image of the sugar-sweetened beverage turning to fat when it gets into your body. We have a video version of this, and there's a new campaign that's just out on the subways now that shows how many packs of sugar this translates into. We do think we're showing some evidence of success in this. We have our annual telephone survey of adults in New York City, and we have self-administered surveys of high school students in New York City that are showing reductions in self-reported consumption, not just of carbonated sugar-sweetened beverages, but with all sugar-sweetened beverages over the last few years. We still think there's more that needs to be done, though. As everyone here probably knows, we have been supportive of the idea of again, borrowing an idea from smoking, of a tax on sugar-sweetened beverages at a penny per ounce. And this is the rationale behind that, that there is an elasticity to the prices of sugar-sweetened beverages, as there is with any other product. Elasticity means the more that you increase the price, the more the sales go down. There have been estimates from a variety of studies in the literature about the elasticity of different food items. Food in general is not very elastic. People have to eat, and so they're going to buy food regardless of its price. But there are ranges within food. So eggs are treated more as a necessity. This price elasticity of minus 0.2, which means that if you increase the price of eggs by 10%, then your sales will go down by 2%. But if you get down to soft drinks here, the elasticity of minus 0.8 says if you increase the price by 10%, the sales will go down by about 8%. That means amongst foods, soft drinks are treated more as a luxury, something that's more discretionary. If the price goes down, well, maybe you'll purchase something else instead. That says that we can predict with a fair amount of assurance that if we increase that price, we will see a reduction in consumption, in sales at least, and one would hope with consumption. That tax was proposed in the legislature last year and the year before, and it didn't get through, but it made a fair amount of progress, and we're still hopeful that at some point a tax will pass. We have also announced, as you've probably heard recently, a proposal to change the policy for the SNAP program, that's Supplemental Nutrition Assistance Program, better known as food stamps, to make it so that you no longer can use food stamp benefits to purchase sugar-sweetened beverages. And here's the rationale behind that you can use this SNAP benefits to purchase any food, but you can't use it to buy alcohol like beer. You can't use it to buy tobacco. You can't use it to buy things like aluminum foil or paper products or pet food. That it's sold as a nutrition assistance program. If it's a nutrition assistance program, then we probably shouldn't be allowing it to be used for that one product that we feel like is driving our biggest nutritional problem in America today. That contributes to the obesity epidemic, and that if we make it so that people can't use that if they choose to, they can still use their own money to buy sugar-sweetened beverages, but if only a percentage of them do and the others don't, then we should see a reduction in sales and consumption, and we might be able to help turn around the epidemic. This is something which is a proposal for a demonstration project that is under consideration by the USDA, and we don't know whether they'll approve it or not, but we're hopeful. So I guess the larger point here is that there are ways to change our food environment in the same way that we changed our environment around smoking, that we think can have an impact on the consumption of food by all of us and have benefits for the obesity epidemic and benefits for health related to unhealthy diet in general. Okay, so that's a way of thinking through approaches to health. Now let me just get on to the idea of where does research fit into all of this. And I want to discuss this by contrasting what I would say is sort of a traditional biomedical model approach to research, which is important, which we need to continue to do, with a public health model, which I feel like is also important, but is under-recognized. So a basic biomedical model says, well, first you need to do basic research. You identify diseases and you classify them. Somebody either has a disease or they don't. It's binary. And then you do some sort of basic and clinical research to understand the pathophysiology of that disease. And then you look at differences between individuals. Why did person X get this disease and person Y not? What's different about the biology of those two people that made this person get a disease? Now, a public health approach, public health approach says that unhealthy biologic markers and risk occur across the continuum. So somebody has higher blood pressure than somebody else, but hypertension isn't really a disease. It's not binary. It's just there's a risk across the continuum. Risky behavior occurs across the continuum. The basic research of public health is to look at patterns and trends in health problems in populations. Okay, so why does this entire population have greater blood pressure than another population? It looks at similarities between individuals and differences between populations. So why are obesity rates in the Bronx higher than they are in Manhattan? Rather than why does one person in the Bronx have greater weight than somebody else who lives next door in the Bronx? So that's the basic research in public health. Let me go to the development here, research on the biomedical side. Development is usually includes laboratory testing. We're targeting individuals, find out what's really different in that one individual versus another. We ultimately get into development of some sort of treatments, and the absolute definition of good science is a randomized controlled trial. Okay, if you're doing it right, you're doing a randomized controlled trial. If you're not, then you're not really doing good science. And the focus, the ultimate outcome of all this is cure. On public health side, the sort of development includes observational studies and looking at natural experiments within populations. We can almost never do a randomized controlled trial of the sort of interventions which I'm talking about here. You can almost never randomize 20 cities to one intervention or one policy and 20 to not. And so good science has to involve other types of designs like quasi-experimental studies, time series analyses. And the ultimate outcome of all this is on prevention. It's on how many people didn't develop the disease, which is actually a lot harder to measure than how many people got cured of their disease. So the outcome is the improved health status of the population. And then what about application? On the biomedical side, we think about how we translate into clinical practice. Our goal is to get some tool in the hands of doctors that they're going to apply in the clinic. And there is no, or almost no, consideration about cost or scalability. If a doctor can do it, it's going to be reimbursable. That's really not an issue. On the public health side, our ultimate goal is some sort of adoption of a policy. And our cost and scalability are absolutely essential. There's not a lot of point in applying something, in developing something that we think ultimately can't be scaled up to an entire population if we're looking at a population-level health problem. Someone gave me this example once, which I like. We could probably imagine that we could prevent any individual from becoming overweight if we gave them, I don't know, let's say $10,000 every week for which they didn't gain any weight. All right? Probably that's enough incentive that it would work. But there's no way we could scale that up to the entire population, so there's no point in measuring that incentive. There's no point in studying that. We have to think, well, obesity is a population-level problem. What can we do at the population level? And then work backwards from there. So that the biomedical model is absolutely valuable. The public health model is absolutely valuable. But I want to think about how have they played into the greatest successes we've had in health. Well, back around 2000, the CDC went back and said, what were the biggest health achievements of the 20th century? And these are the ones that they listed. And what I did was I think, well, to which of these were really developed through the biomedical model that ultimately was translated across the entire population? And which of these were developed through a public health model? And clearly, vaccination, absolutely. That's a biomedical intervention that's had broad population benefit. Family planning, absolutely. Then decline in deaths from coronary heart disease and stroke. That was been a mixture of better treatments for hypertension and high cholesterol with public health approaches. Healthy Mother and Babies likewise is a mix. But all the ones that are in white here are really public health interventions. These are population level environmental changes which have been developed outside of a laboratory, have been developed through a policy development process, and then later have been demonstrated to have this population level benefit. And so likewise, I think over the next 50 years, the next 100 years, our greatest benefits many of them are going to be coming from policy change that won't bubble up from a laboratory. It's going to be sort of coming through the policy arena, and we'll ultimately see its benefits as we evaluate that. So then that gets to the question of if we want more public health research, and I think we do, what's a good public health research question? And my way of thinking about this is that we should work it backwards. We should first say, well, what policies or interventions might work for the entire population? So if we put all of you in a room to say, okay, what could we conceivably do to solve the obesity epidemic in the Bronx that would actually work? Forget for the moment the politics, the cost, what actually might work? And then you say, well, now what questions would we have to answer to figure out whether it really would work? And that's then what I think are good research questions. So you think, well, okay, would it really be effective? What would be the unintended consequences of that policy or approach? What would be the cost? What's the feasibility? What's the amount of community support? All of that, these are important questions which can and should be answered by research, by units like you. And so I'm encouraging you to think this way because that's the sort of thing that's going to be helpful to all of us as we really try to address population level solutions. So here's an example. If we wanted to think about smoke-free building entrances, which I know you have here on hospital grounds, but in general we don't have in New York City, should we have a policy that makes smoke-free building entrances? We'd want to answer questions like, well, what percentage of building entrances right now have people smoking nearby? And what are the levels of secondhand smoke that people would be exposed to as they go in and out of a building? And how much exposure are they getting there as they go in and out? What are the health effects of that exposure? If those entrances are smoke-free, what would the compliance be like by smokers? Would they ignore it? Would they move elsewhere, expose people just as much? What would be the effect on the quit rates of smokers? Would that have an impact? How much support is this for the policy among smokers and among non-smokers? We're not, by the way, considering this at the moment, but I don't have answers to any of those questions. I would love to have answers to those questions because that would help us figure out whether this is an appropriate and useful policy as we're trying to further our smoking prevention efforts. So let me just finish by saying that if we want a broad population level impact, something that we can measure, the health of our population has gotten better, then we're going to be addressing these mass diseases and mass exposures. And that's going to require some sort of mass remedy, some sort of policy or environmental change remedy. And so that's what I think that the payoff is, and we absolutely need research that feeds that. That research doesn't take place in a laboratory, so it may not be so sexy as the sort of research that we've thought about in the past. Nonetheless, it is just as important, if not more important, than what happens at the cellular level. So if you're doing this sort of research, we'd love to work with you. And let me stop there and answer any questions. Yes?
Thank you very much for an excellent talk. You made many excellent points. I have 3 points that I wanted to see if you could sort of tie together and get your comments on them. And they actually relate to the sugared beverage issue. So you're undoubtedly aware that there's been some criticism of the SNAP demonstration project idea because it kind of selectively targets a segment of the population, namely those who used to be called food stamps. An alternative that's been suggested, in fact, I once did a town hall with former Governor Mike Huckabee, is to actually increase the value of food stamps if you get fresh fruits and vegetables. Carrot rather than a stick of bread.
Right.
So that's one point. The second point is there's always inverse correlation between obesity and socioeconomic status as a surrogate education. This is in all the CDC, Rufus surveys, etc. And you didn't explicitly comment on that. And finally, a root cause, one might argue, of the sugared beverage issue. taking the approach of taxing is interesting. That runs into obviously political problems, but the political problems for what I'm going to suggest are equally, if not more daunting. But aren't we as a country subsidizing through subsidies to corn and other agricultural providers high fructose corn syrup, which is very artificially lowering the cost of these sugared beverages?
Yeah, great questions, all three of them. First, the idea of using food stamps, positive incentives for fruits and vegetables is a good one. I like that idea very much. There's a pilot for that going on in Massachusetts. I don't see that as replacing our approach, but being complementary to it. I've learned in dealing with food that there is very little political resistance to try to increase access to healthy foods. But I also think we're not going to get there in solving the obesity epidemic unless we somehow reduce accessibility to the unhealthy foods. That as much as there's talk of food deserts, in fact, we are drowning in food. Where there's food everywhere you turn, and it's unhealthy, calorie-dense food. Unless we change that food environment with the excesses of unhealthy foods, I don't think we're going to solve the obesity epidemic. Remind me the second and third questions.
Inverse ratio obesity.
Oh, the obesity and socioeconomic status. It's a very strong relationship. The relationship with race is actually a little bit stronger than with socioeconomic status. And as much as I've thought about this over the years, I'll have to confess I don't really know what the reason is for that gradient. You do wonder whether this program that provides free accessibility to foods that are unhealthy, such as sugar-sweetened beverages, might actually support that problem. But I don't know the answer to that. And I don't think that greater education is going to solve that problem. I think it's something about the environment to which low-income people are living that contributes to that. But if we understand that, I do think we'll be a lot closer to the solution. And the third one was high fructose corn syrup. Oh yeah, the subsidies. That is something I do worry about too. That we are artificially driving down the price of very unhealthy food through our farm program, and that's something that we should be taking on seriously too.
Impossible because there's no alternative on a tobacco product that is safe. But is it possible to work in collaboration with the soft beverage industry? They are alternative to sugar drinks. Are policies being thought about preferentially taxing the sugar versus the non-sugar beverage and so forth?
Right. Well, the proposal we had here in New York State was for a tax on sugar-sweetened beverages. It would not have been a tax on diet beverages, or it wouldn't be a tax on water. And all the beverage companies do sell these other beverages that don't have any calories on them. And so my feeling is, yes, that there ultimately can be common ground here where beverage companies can continue to make products and make a lot of profit, but just not be contributing to the obesity epidemic by not pushing the ones that have high calories. I don't think we've gotten there yet. I think that the beverage industry is just simply resisting the efforts that we're making, but I remain optimistic that at some point we'll find some way of working together.
Just to welcome you to our environment. You don't have to tell the audience that they can ask questions.
That was an absolutely fabulous talk. It's probably one of the best talks on obesity I've ever heard, so thank you very much. How do we, let me step back. I'm very intrigued by your remarks on quasi-experimental designs, and we've seen some very good examples of that. It's like, for example, comparisons of what happened on the English-Scottish border when smoking bans were implemented in Scotland, and there was a sudden decline in admissions for myocardial infarction in Scotland that didn't happen in England. Mm-hmm. How do we set up a nimble research environment so that when places like New York City institute new policies over a relatively short period of time, we are able to evaluate them and do quasi-experiments quickly?
Yeah, great question, and that's exactly the sort of areas which I would love to have our department working with units like this one more in the future. I think first we need to have good databases that we sort of have on an ongoing basis that you can tap into immediately or in retrospect, because often you don't really know when that policy is going to take place, and so you can't plan it that much in advance. To the extent that you can plan in advance, we certainly sit down and think, how are we going to evaluate this, and what can we what baseline data can we grab right now and what comparison populations can we grab right now. But there's a limit to what we can do. And so we welcome collaborations with researchers that say, I've got a good data source from New York City and a neighboring population on this issue. Would love to be able to figure out how to combine that with the policy change to evaluate its impact.
Your research questions largely fell outside of the traditional fields that we think of as medicine and even public health. You're talking about marketing, not health economics, but market economics, public policy, social science, political science. I wonder how we can find the scientists that want to collaborate on these issues, and because we're challenging our own paradigm of where the limits of biomedicine and public health are, and requiring a level of interdisciplinary collaboration that we have yet to see.
Yeah, I think to a certain extent it could be that recruiting scientists with different backgrounds. So you may want to be looking for economists, so you may want to be looking at sociologists, but also to a certain extent it is people with existing expertise just training their research questions somewhat differently. So with sugar-sweetened beverages, I still feel like we don't have a good answer whether high fructose corn syrup is fundamentally different from sucrose in contributing to this problem. So that's a laboratory rat sort of study that people who work in labs can, I think, need to do more on. But there are other questions about how do people consume these products, and so you can do studies on people individually as well as how do people perceive advertising, and so then that can draw on people who have a psychology or sociology background. So I think it's going to be a combination of the two, but I think you can get there without huge leaps from where you are now.
I think we need to stop here. Oh, you have a question?
Yeah, I think at least one potential answer to Dean Spiegel's first question probably is the genetic substrate, right? Why certain populations are more susceptible. I mean, I'm reminded of the fact that there was a recent non-surprising item in the news about the relatively trivial amount of weight gain required in Indians in this Indian subcontinent to spike the incidence of diabetes, type 2 diabetes in populations. And of course the PIMAs are the U.S. Marker for highly susceptible populations. And for those of us working in the Bronx, of course, Elizabeth Walker, who's here from the NIH-funded Diabetes Center, and she's director of the Prevention and Control Unit, works with the DOH on some of these projects. The question is, can the public health focus take into account especially vulnerable populations? I mean, for us, the substrate of folks programmed genetically to have a greater impact of mild weight gain on the ultimate contributor is diabetes. There's a lot of evidence that weight gain alone is not necessarily the driver of cardiovascular disease. But the question is, where's the interface between looking very intensively at targeted populations versus the broader public health approach?
Yeah, I certainly think that there is a genetic component to really all diseases. Certainly there's going to be a genetic component to obesity development and diabetes development. And I think understanding that is valuable to understanding the broader epidemic. I keep coming back to, maybe this is too narrow a view, but from my perspective, I can't change genes. Okay, so if we came to this and said, this is a genetic problem, then I just throw up my hands and say, well, you haven't helped me at all. And so it's useful to understanding it, almost more from my perspective, to control for it in our other evaluations of our policies to see if we've had an impact. Because we certainly want to have an impact on everybody, whether they have genes that make them highly susceptible or genes that make them less susceptible.
About 5 more minutes.
I want to follow up on this issue of populations and genes, especially when you talk about often this relates to what we consider to be minority or economically deprived populations. They're highly heterogeneous. They really aren't genetically homogeneous, regardless of the social labels that we put onto it. So how do we go from population studies to make sense of them if we really want to look at vulnerable populations?
I don't know. I mean, I agree with the genetic heterogeneity. To me, again, trying to address the obesity epidemic, I'm not really sure that there's a huge payoff to knowing more about that, because 30 years ago we didn't have this epidemic and our genes were no different. And so there ought to be a way to get back to that thing without having to get those genes changed or to understanding more about those genes. So again, I come back to, it's sort of useful to know in general so that we understand the epidemic a little bit better, but it's not ultimately going to change, I don't think, what our solutions are, any more than knowing that some smokers are more likely to get lung cancer than others based on genetics helped us reduce smoking rates.
Dr. Farley, I wanted to get your take on an article on the front page of last Sunday's New York Times that I found very depressing. I was hoping you could make me less depressed about it. For those who didn't see it, this was the article about what's happened with cheese consumption and the government role, essentially as a reflection of our success in getting people to drink less milk and less whole fat milk. We've created a problem for the dairy industry. So in order to help the dairy industry, we have two things happening simultaneously. Government issued guidelines telling people to eat less cheese, and then government funded efforts to get people to eat more cheese. And would really like to know how you see a way out of this kind of mess.
Yeah, I had heard of that before that article, but it laid it out much more bluntly than I'd seen before, that our efforts to have people switch from full-fat milk to low-fat milk had basically driven down the price of cheese, and so that cheese consumption had gone up, particularly on pizzas, which is another big contributor to weight gain in the last 30 years. And as a nutritionist once told me, they said, once that milk comes out of a cow, they're going to figure out a way to get you to eat it, okay? And so I think that just the broader lesson is that government policies have a big impact. That as much as we think of ourselves as being very conscious eaters, as a population, we are often sort of passive consumers of whatever is out there in the market. And so we do need to think about farm policy and dairy policy as being important influences on the health of the entire population.
So is the other Tom going to have an impact at the CDC level? We've had more nimble.
Let me say I have enormous respect for my predecessor, Tom Frieden. And if I'm half as successful as he was at this job, I will feel like I've done my job well.
Last question.
On a public health note, when you go to a restaurant and you order a main entree, it's usually costing you $14, $15, even if you're all by yourself, and you end up either overeating, or taking it home with you and eating next day, whether you want it or not, because wasteful to throw food. Is there a program where you could evaluate whether entrees are available in a smaller portions, a half portion, so I spend less, I eat less, and I stay healthy?
Right. Yeah, I mean, one thing we know is that food is sold in portions that are far too large in restaurants, and also that people will pretty much eat whatever you put in front of them. There have been a variety of studies in laboratories on portion sizes that show that you give portion size that may range of over a factor of 2, people will consume it and they'll feel satisfied, no matter where in the range that is. Then there's a real question, what to do about that? And I haven't figured out what to do about that. I mean, we can say to the restaurants, please have your restaurants in smaller portions, but there's an economics to this that they've learned, that the price of putting food on your plate is pretty much the same, regardless of whether it's twice the size of a normal portion or not, but they can charge more for it if it's a larger portion in general. People feel like they're getting something more for their money. So I don't know how to change that economics, but that is definitely a contribution to this problem.
All right, I would like to. We could go on forever. This is great in one way, but it's all right.
Okay.
Quickly.
Thank you very much. Since there is an increasing recognition that many of the chronic disorders that you've listed, heart disease, cancer, and the likes, clearly began in utero, a question that comes to mind, if indeed the hypothesis for fetal origin is true, how much effort is the New York City going to put into the health of girls and women, and more specifically of pregnant girls and pregnant women?
You know, we put effort right now into improving the health of women, and I'm not quite sure what we could be doing differently, but I would be open to suggestions for someone to say, you know what, here's something which you're not doing which could improve the health of women and therefore improve birth outcomes and reduce chronic diseases down the line. I mean, I don't know, you I'm sure know better than I, the literature on the in utero risks and long life effects, but I come back to that, okay, well, then tell me what we should be doing differently. And if it's something that we are neglecting now, I'm open to, you know, trying to figure out how to do it.
Investing more into girls and women would probably be the first step.
Yeah, investing how still is my question. So.
Education, healthcare, pregnancy prevention.
Yeah. Yeah.
Right.
Yeah. More discussion we have time for, I think. Yeah.
Mine is just a sort of an observation from my biased opinion from a South American. Usually I see down there that people who are rich are the ones who are obese, and the people who are poor are the ones who are very skinny. I think the relationship here is actually the opposite. So I wonder how, as opposed to Gene, is also kind of people who are poor down there don't have access to any food. People who are poor here have access to bad food. So that's why maybe they become obese. I mean, something like a theory.
Yeah, you know, it's changing through Latin America too. I was talking to some people from Pajo the other day, and obesity, even among the poor, is becoming a big problem through many areas of Latin America. It is what we're seeing as countries develop these days. Is initially obesity is a problem in the high-income people, and then it shifts to the low-income people.
Okay, we got to bring it to a conclusion.
Okay.
I want you to join me in thanking Dr. Quarry.